Good morning, you all. Is it my voice is audible for you? Shalini, voice clear unda?
Yes, sir.
Okay. So anyhow, I can understand you are having exams, but definitely we are supposed to take the classes also, na? We'll do at least 1 hour class. I will be taking 9:30 to 10:30. So today we'll discuss about estimation of hemoglobin, blood transfusion, and cross matching. And hemoglobin estimation and cross matching, I will show you the experimental part also. Some videos I am having which we were used for our workshop. I will be using for your presentation. So first of all, I will explain you the hemoglobin estimation. See, in the last class we discussed about blood transfusion. When you will be doing the blood transfusion, when there is a need, when there is a lot of loss of hemoglobin, anemic conditions, when there is a matter of, see, if hemoglobin content, normal person should have 12, 14 to 18 in case of male, and in case of female it should be up to 16. So if it is 14 or 12, generally transfusion is not recommended. What happens if the hemoglobin gets reduced? Anemic oxygen carrying capacity gets reduced. So if the oxygen is not sufficient available, then the tiredness, one a patient will face the tiredness, and he will not be able to do activities, and a lot of sweating you can see on the patient. So just based on that tiredness, or a person's not ability to do something, will not do the transfusion. Generally, if the blood loss is huge, then there is a possibility of a person to go into shock. A person may go into the shock and he may die also. So in such cases, see, when you are doing a surgery, already the hemoglobin content is less. If the hemoglobin content is 8 to 10, hemoglobin, if you see the hemoglobin, it is a 64 kd molecule protein, and it is a globular in shape, and it represents 34% of RBCs. So in RBCs, the volume wise 34% is hemoglobin. Then iron molecule is there, and the other things are also, the membrane is also there in that one. So 4 subunits are attached to the heme, and generally for estimation we will be using the Sahel's method. Sahel's method is the principle is convert. There's a by using the acid. By using the acid, we will convert the hemoglobin into hematin. Red colored hemoglobin will be converted into hematin, which is a brown color. And see, we'll be using a standard reference tube. To achieve that standard reference, how much amount of water is required, that is actually considered to be the there's a Sahel's methods. So here the principle is, by using the acid, by using the acid, how much, see, we'll be converting the hemoglobin into hematin. So the red colored one will be converted into brown colored one, and this brown colored is matched with the standard reference colored by diluting it with water. So the water required, or the level of water required, represents the hemoglobin content in it. So what we'll be doing, you'll be having a central graduate tube here. This is a central tube. This is a central tube. I'll show you the experiment part also. This is a graduated scaled tube, and two standard tubes on a side. See, this is the one, and this is the another one. Two tubes are there adjacent to the graduated tube, and this entire setup is there in, there's a hemometer, or Sahel's hemometer. This one, see, this is the central one, and these are the two side by side standard reference. You are supposed to dilute the hematin as such that the concentration is, this color is going to obtain the same. Uh, can you wait for half? Just sit over there. Because you told me 10:30 you are coming. That's what I thought of taking the class. Huh? Yeah, just as I started, half an hour I will wind up. Please sit there. And we'll be having n by 10, that is a zero point 0.1 normal HCl solution, distilled water, and a special pipette of 20 microliter capacity. Droppers and glass rods are required. I'll show you this. This is the pipette of 20 microliters, and you require pricker as well as dropper. All the things are required. So the procedure is concerned. First of all, you need to take in graduated tube, the center tube. You are supposed to take 20% of n by 10, that is a zero point 0.1 molar HCl into it. 20%, that is it is of 1 ml tube. You are supposed to take 20 milliliters of 200 microliters of n by 10, that is zero point 0.1 normal HCl you are supposed to take. And with your bulb tube, you are supposed to make a prick on your finger, and better you discard first drop, first fluid, then you squeeze your hand, and with the tube you take 20 microliters of blood. You withdraw 20 microliters of blood, and this withdrawn blood you add into the central tube, which is already having 0.1 normal 200 microliters of HCl in it. Okay, then you allow it for some time. Then what happened? Acid reacts on hemoglobin. Then hemoglobin is converted into hematin. Then mix it with a glass rod. You are supposed to take a glass rod and mix it vigorously. So the hematin will be broken down. Hemoglobin is converted into hematin, and hematin is broken down, and you will be getting a brown color. More the concentration of hemoglobin, more the brown color you will be getting. Okay, then allow it for standing for 10 minutes, and mix it well. Then gradually you are supposed to add the water to it, so that your central color is going to match with the adjacent color. Now on that one, see, on the scale there will be percentages. On the scale there will be percentages. So up to which point you have added, that indicates the percentage of hemoglobin. One side it is given as a percentage, other side it will be given as a grams per 100 ml. See, adult normal value is 14 to 16. There is average of 15. Adult female 12 to 15, average 13. A newly born babies 18 grams, and children should be 12 grams. And uh, see, hemoglobin gets reduced in anemic condition. One could be loss of blood due to accident or whatever the injury, and second, maybe the hemoglobin may not be produced, or abnormal hemoglobin may be produced, like leukemia cases. And polycythemia is a case where hemoglobin is produced in larger extent, larger quantities. Like generally, polycythemia is the condition in hill regions where the oxygen condition is very less, so that more amount of hemoglobin is produced, so that whatever the minimum of amount of oxygen is there, that is trapped. Okay, and the hemoglobin, what we do, the estimation is also useful to calculate the mean corpuscles HB, and these are the equations we are having. Based on that, we'll be doing. Here, there is a one experimental part. I'll show you. It will be easy to you to understand. See, these are the things. This is the Sahelis setup. This is a central graduated tube, and these are the two reference. First, you are supposed to take up to 20%, that is 200 microliters of zero point 0.1 normal HCl you are supposed to take. This is the thing. This is a central tube. Now we'll be taking the blood. See, this is the pipette, 20 microliters pipette. This is the mark. Up to this mark, you are supposed to take the blood exactly up to that mark. That measures 20 microliters of blood. So you are supposed to make a prick. So First drop, better you clean. Now squeeze it again. You got a drop. Now you take it with your mouth pipetting. Exactly 20 microliters you are supposed to do. This is the 20 microliters of blood drawn. Now add this blood into there is a zero point 0.1 normal 200 microliters of HCl. See the color, you can see now color got changed into the brown color. Now allow it to stand for 10 minutes. Now we are adding distilled water. Just make it clear. Acid 0.1 normal HCl is added in the beginning itself, not later. Now add the water. And with a glass rod, we are supposed to disturb the cells. So the RBCs are ruptured, and whatever the hematin that is created, that is produced, that will be coming out. Allow it to stand for 10 minutes. And now you should make up with water. So the color should be matched with the adjacent reference standards. So it is a dark brown in color. We should get the paler color now. See here the central tube will be having percentages as well as grams readings. Total 15 is taken as a 100% in case of male, and 13 is taken as a 100% in case of female. Ten minutes digestion time is there. Once 10 minutes is over, then we are supposed to adjust the color by adding the water. So it is now being diluted. It is being diluted over there with the distilled water to match the color. See, now it is matching. Once it is matching, see either grams in grams or percentage. Matching perfectly. We'll take it out and we'll see how much percentage it is contributing. It is grams, it is showing 13 grams. 13 grams per 100 ml. The reading is 13 over there. Yeah, 13. 13.5. 13. Exactly 13. if it is in percent, other side of the scale will be in percentage, but it is better to follow, because percentage varies to male and female, calculation will be difficult. So it is better to follow the grams per 100 ml. That is also percentage. So this is the one experiment, uh, that is a hemoglobin estimation. Second, see, based on the hemoglobin content of a person will decide whether to go for a transfusion or not. Whether to go for a transfusion or not will be deciding based on the hemoglobin content. If the hemoglobin content is too less, then is it straightforward? We are supposed to, we did for the first hemoglobin estimation, then blood grouping will leave. Then is it directly we can
Today
do
I
the
am going to
transfusion?
talk about
We
major
are
minor
supposed to do the
cross
cross
matching.
matching. Here I will show
Materials
you
required for cross
experiment
matching
of
will
cross
be
matching.
donor and recipient blood samples collected in EDTA and serum separation tube respectively, 0.9% normal saline, and plain tubes without anticoagulant. You may also require a centrifuge, incubator, a microscope, clean glass slides, pipette tips, etc. Collect the samples and mark them
See,
respectively.
this is the blood samples collected from the donor and recipient.
Invert the test tube several times to check for clots.
It is a very
After
simple
checking, they
concept.
are good to go for centrifugation.
We'll be separating the
If the sample
RBC
is
and
submitted in serum
serum
separation tubes,
from
then
donor
you
as
need to
well as
centrifuge
recipient.
it for 4
This is
minutes.
the centrifugation process we are doing. So we are separating blood
While the
as well as
centrifugation is going on,
blood is
start
separated
marking
into,
the test
there is
tubes.
a RBC plus serum.
Any sort of clean test tube can be used for RBC washing.
So after the centrifugation is done,
Take 4
we'll be
clean
taking out.
glass test tubes and start marking them as follows. Donor blood recipient serum as major, recipient blood donor serum as minor.
Here the reactions are
Donor
considered as a
control will have donor
major
blood
and
and donor
minor.
serum. Recipient control will
In
have
major,
recipient
you are
blood and
looking the
recipient serum
antibodies
respectively.
of
Start separating
RBC.
plasma
In
after
minor, we are looking the
centrifugation.
antibodies of serum.
Plasma can be separated and transferred into a plain test tubes.
See the plasma, because we didn't allow for the
The
clotting.
packed
So we'll
cells
be
in the
separating the
lowermost
plasma.
bottom will be taken for erythrocyte washing.
First, we'll be separating the plasma of donor and
Start
recipient.
separating the serum from donor sample and transfer it
Okay,
to
see.
tubes that are named as minor and donor control respectively. Because both minor and donor control requires donor serum or plasma. Recipient control tubes. After filling serum in all the test tubes, leave them
The
aside.
serums are separated
And
now.
let's start processing
The
the
plasmas are separated.
RBCs. Here is where we
Now
require
the
0.9% normal
RBCs are
saline.
washed. We'll be using the normal saline.
Take the tubes
Normal
that are
saline, because
previously
it is
marked
having
as
the
donor
similar
RBC and
osmotic
recipient
potential. The
RBC
RBC
separately.
cells does not get sliced.
Take around 200 microliter of packed RBCs and transfer them
After the
to tubes
washing, we are taking
separately.
the washed RBC cells. Washed RBC cells are
After
taken.
transferring,
See, sometimes
add about
maybe
4.8 ml of
similar blood group is there,
0.9%
but
normal
they may
saline
be
to the
having
same
some
test
cross
tubes.
reactivity.
Invert
To
the tube
eliminate
several
that
times
one,
to mix
we
the
should do
RBCs with
this cross
normal
matching.
saline properly. Once both the donor and recipient RBCs are mixed with normal saline, start with centrifugation. Centrifuge the samples for
This is the
1 minute.
washing phase of RBC.
After centrifugation, discard the
These are the
supernatant.
washed cells.
Supernatant can be discarded either by decanting or pipetting out. Repeat RBC washing with normal saline 2 more times.
So these are the washed RBC cells. We'll be taking the
After the
RBC
third
cells.
RBC washing, gently pipette out the supernatant from both the test tubes.
Now we'll do the cross. See, here we are looking for antigen antibody reactions.
And make final RBC suspension with normal saline.
Normal saline. Again, they are being suspended with normal saline.
Invert the tube several times. Now they are ready for cross matching. Take donor RBC, Pipette out 200 microliter and add it to the major test tube. Add the same to the donor control.
See, one person's donor's blood is reacted with the
Similarly,
serum of
pipette out
recipient,
200
like vice
microliter
versa
of
it is done.
recipient blood and transfer it into minor test tube and recipient control tubes.
This is recipient blood and donor serum.
After adding donor
So
and
these are the four
recipient
setups.
samples,
Two are major, two are
it is
minor.
time for incubation. Incubation time is around 37 degrees
Incubate with
Celsius for
37 degrees
15
Celsius
minutes
for some
or
time.
30 minutes at room temperature. Here I am setting the timer for 15 minutes because I am incubating at 37 degrees Celsius.
It is room temperature,
After
it will give us 30
incubation,
minutes.
take out our samples and centrifuge for 1 minute. After centrifugation, examine the supernatant for hemolysis.
If the hemolysis has occurred, then the entire thing will turn into red color.
Start pipetting out the
And you can
supernatant
see the
until you
agglutation
have
also on the
very
slide.
little
See,
supernatant left
remove
behind.
supernatant and take suspend whatever the pellet is formed.
Start mixing blood and plasma and keep a drop on examination slides.
Put it on the slide. Are two major, two minors. We're supposed to take.
Look for gross agglutination.
Like what we do in blood grouping, you are supposed to
If you
keep
don't
finger
see any,
here.
then proceed with microscopic examination by
Here there is no
adding a cover slip.
agglutation.
And
See, the
finally,
free floating
this is how a
RBCs will be
compatible
emerging in here.
samples will look like. You can see individual RBCs that
See,
are not
compatible.
clumping
It
with
means
each other.
this donor can give the blood to this recipient.
This is how an
See, this is
incompatible
how it
sample will
happens
look
if the
like
same
under microscope.
non-matching bloods are there. They are of same blood group.
If you see RBC clumping either in major or minor or in both,
See,
then they are not fit for transfusion. Agglutination can be differentiated from rouleau formation by adding a drop of normal saline. Rouleau formation will get
Rolo formation,
disintegrated in
the
normal
RBCs will
saline,
be
whereas
clumped together
agglutination will remain the
sometimes.
same.
So if that is the case, you add little amount of water to it, and that can be easily removed from there. So actually, blood grouping, only by doing the blood grouping we cannot do the transfusion. Maybe A group, see, universal donors are there, universal recipients are there. That is, see, major precipitation reaction may not be taking place in that case if the same blood group is there. But there is a possibility. It is not only the ABO antigroup and there's antigen antibodies as well as RH antigens. We have some other things also which will be playing important role, which are minor. Actually, A, B, R, RH, they will be coming under the major, which will destroy the RBC if at all they are present. If the antigen antibody of blood grouping is taking place, that it will destroy the entire RBC. Hemolysis takes place and it creates a lot of problem, hypersensitivity, and several disorders, several issues will be coming over there. So first you are supposed to do the blood grouping. Second, cross matching. In cross matching, simply you have seen, but again I will repeat you. First, you will be collecting the blood from the donor and recipient. Will be from donor and recipient. You will be separating serum, sorry, plasma and RBC cells. RBC cells are washed here, and it will be taken into four groups. It will be divided into four groups. See, one group, the donor's blood, and recipient's plasma, and another one, there's a recipient blood, and there's a donor's serum. These are considered as a major, and in this case we are looking for the these blood groups A, B, or something. If they are not matching, that things we are measuring here, And apart from that, we are doing the control also. See, the same thing, washed donor cells and donor plasma, and washed recipient RBC cells and recipient serum that will be taking. But anyhow, in minor, will not expect any precipitation. But in major, if any issues are there, then you will be getting a precipitation, and that you should eliminate such kind of blood transfusions. I'll brief you something about uh, blood transfusion. Already we did this blood transfusion in the last class, but I know that you are preparing for exams also, but I'll do in brief. Even some guest is waiting for me also. So, blood donation. Who can do the blood donation? You know, many people are conducting nowadays this blood donation camps. Who can donate and how much he can donate? Just a lot of information is there in this one. I can provide you this slides also. And the healthy adult donors, he can donate 450 ml, and there's a plus or minus 10%. Like it goes to 500, 400 to 500 ml. A person can, whole blood can a person donate. And see, 1 unit means 300 ml. So he can donate. There is a almost 1 to 2 units, 1 to 1.5 unit he can donate. He cannot donate more than that one. And male can donate 5 times per year, female can donate 4 times per year, and there should be a gap of 8 weeks in between two donations. And this is actually the machine. Sometimes it may not be the whole blood required. Sometimes packed cells may be required. Sometimes the plasma required. Sometimes platelets are required. Sometimes clotting factors are required. Sometimes, like based on the requirement, the fragments, the fractions of the blood are separated. See, if suppose a person is suffering with dengue, where the platelet count has been reduced a lot. In that case, you are supposed to do the platelet cells. And in some cases, like surgery is there, or heavy loss of blood is expected. In that case, a uh, fresh whole blood is given in that time. See, sometimes hemoglobin plays important role. In such cases, you are supposed to do the packed cells. Only the RBC, full RBC will be given. Some like hemophilia is the case, where clotting factors are given. Clotting factors, especially eighth is clotting factors are removed, and they are given. And blood preservation, this is also there in our syllabus. Actually, for this only, for blood preservation, already blood transfusion is over for our class. This blood preservation I will do. Generally it is, see, one, if you are a person is donating a blood, he may be having some bacteria or some pathogens, viruses also in it. So if you incubate 1 to 6 degrees Celsius, where the metabolic activity is completely arrested, so majority of the time the bacteria or viruses will lose their life. They will be lost. So immediately, see, except surgery and fresh blood is required. Generally, the blood is preserved at 1 to 6 degrees Celsius for some time, and it is given to the patient. So virus load and microbial load substantially gets reduced. And some cases, like if you frozen RBC cells, like -80 and -196, like liquid nitrogen conditions, and we are supposed to do with glycerin. Glycerol, like your bacteria, glycerol stuffs you are preparing, you are doing the preparation of RBC also with glycerol, so it can be preserved for a longer period. So generally, when you store the blood, in normal case, the ATP and DGP gets reduced, and fragility of the cells will increase, and HB, sometimes HB also shoots up because water is removed from there. Ammonia, potassium also gets increased. This is the one problem. If a person is frequently getting transfused blood, then the hyperkalemia, that is, the increased potassium levels causes. Okay, and pH gets reduced, and platelets are generally lost within 2 days. So platelets, if you require, it should be done freshly, and the coagulation factors are also gets reduced. And Platelet cells, generally it should be preserved in liquid stage, and 1 to 5 days, not long days. Plasma should be fresh or frozen, and blood components are concerned. Like you are supposed to separate the blood components. Nowadays, see, earlier centrifugation used to be practiced, but now from a blood, like I have shown you the image in the beginning, you can separate out them all, like whole blood you can do, RBC separation you can do, platelets, granulocyte, peripheral blood, everything you can separate. And plasma, see, you can separate the cells from the plasma, and see, you will be adding some cryopreservatives in that one, and this plasma can be preserved for a very longer period. And immunoglobulins are there in that one, albumin and other things are all there in there. And whenever there is a infection, so any bacterial or viral infection, generally white blood cells are very much required. And these mm, collected and filtered white blood cells, WBCs, are injected to the patients. And when we should do that blood transfusion, like symptoms are severe, like can we first immediately blood pressure gets down if there is a loss of blood, whether it is accidental or whatever maybe. So first line, doctors will never go for the blood transfusion immediately. Like IV fluids, especially denser IV fluid, dextron or something, they will try to inject. And if there is a infection, antibiotics they will try to give. And so if all these things will not work, then only we should think of transfusion. See, if it is about 10, never, we should never do the transfusion. If it is 6 to 7, mostly necessary. And if it is less than say 6 to 10, dependable, like you need to decide what you need to do. And here, symptoms related to anemia may differ from one patient to another from a given HB level. Like some people may be tolerating higher levels. Like even, so, see, suppose 8 hemoglobin is there. Some people are capable of withstanding it, but some people at even 10 also they will not be able to. So it is not the HB levels; it is the symptoms that you are supposed to decide whether to inject or not. So how impact it is going to create? Whole blood, if you are giving HB only 1 gram per deciliter, it is going to be increased. And fresh, like fresh whole blood is generally given to the shock or massive bleeding surgery cases. And red blood cells are given where you are expecting sudden increase, hypovolemic shock, such kind of things. And white blood cells will, per 1 unit, it will increase 5 into 10 to the power of 6 WBCs per unit. And washed RBCs, and there's a frozen RBCs are used. Sometimes, see, blood irradiation, if you are expecting some pathogen in the person, generally if it is a HIV positive, that blood should never be transfused. If you are suspecting some sort of viral, or already the donor is having some disease, then generally, or if donor is expected to have some leukemia, in such cases it is irradiated, like gamma radiation, that blood, whatever the to be transfused blood, it is irradiated. And the load of microbes load is going to be reduced with that one. See, the platelet counts, generally, if it is more than 50,000, not required at all. And if it is less than 50,000, it is required. And generally, uh, see, dengue is a case where the platelet gets reduced. It shoots down to almost 10,000, it comes, and suddenly it goes to 1,000, and then gradually it increases. And see, in dengue, such kind of viral diseases will wait till once it comes to the 10,000, then gradually the transfusion is given. This This types of platelet concentrators, random donor, there's a is given, and pooled. See, random donor packet is, it is collected from an individual person and it is given to the recipient. And pooled, it is collected from different persons and it is collected at one place and it is given over there. This is a aphrasic. This is collected in instrument and it is transfused. And WBC reduced platelets is indication in the same situation like red cells. So as I told you, we should give the transfusion, because transfusion is associated with several complications. It is not that easy. So unless and until it is urgency, unless and until you feel it, there is no other alternative. Transfusion should not be taken place. First, you should do the hemoglobin estimation, then cross matching. Then also you should think that is it mandatory? Is it compulsory? If it is a compulsory, then only you should go for a this transfusion. See, fresh frozen plasma should be given when the congenital acquired coagulation factor deficiency is there. See, our oral anticoagulant overdose, like while bypass surgery is going on or cardiac surgeries are going on, so anticoagulants will be given to the patients. In such cases, because if any something is happened inside, that will lead into huge blood loss, and the patient may be going into the septic shock, and he may be volumic shock, and he may die. In such cases, you are supposed to give the fresh frozen plasma, and this plasma exchange, there's a, after massive transfusion, and there's a 10 to 20 milligrams per kg to increase the deficient factor levels about. See, generally what happen, this when you are doing the lot of transfusion, so what happens here, clotting factors will disappear in such, because as the dilution increases, dilution, this clotting factors decreases. In such cases also you are supposed to inject the plasma. So the practical, is there a need of a transfusion? Which product should be used? Number of units, how much it is required? See, majority of the time before surgery, the doctors will arrange the blood. Whether it is, sometimes it may not be required, but accidentally it may happen that there is a huge loss of blood. So in those, that loss should be compensated. That should be adjusted. Okay, and recheck the blood. See, this is a very important thing. Recheck the blood type of patient and donor, and use the cross matching whether they did or not. Read the label. uh, Due to mislabeling or this happen, see, it is it leads to the loss of a life. Whether is it irritation necessary. See, suppose if today only, like somebody has walked and given the blood, and it has to be transfused by evening or within 1 hour, so it should be irritated. And the temperature, at what temperature it should be transfused, and filters, is it required. Flow rates, generally it is started with 5 ml per minute for 15 minutes, then the rest is 200 to 500 ml per hour. And drugs, like some compressive drugs are required. So, transfusion reactions, immunological reaction, non-immunological reactions, or acute reactions or late reactions. Acute reactions immediately, as and soon you are doing the transfusion. So, what happens due to immunological reactions? Say, suppose the antigens of RBC reacts with the antibody of the donor or recipient, then those RBC gets lysed. If the RBCs are lysed, then what happened? A lot of workload will be created on the liver as well as this spleen. Uh, Mismatch transfusion, transfusion of hemolyzed blood, may be acute or late or delayed. Acute hemo, like it happens 1 in 25,000 cases, and see, 1 in 6 lakh cases, it is a mortal, and 40% are symptomatic. You will be able to see some ABO mismatch is a most of the problem. ABO mismatch is a most of the time it creates this hemolysis issue. The hematin is created that accumulates in liver and spleen as well as your kidney, so it leads into the acute renal failure and shock. And so what happens? Then what you need to do, stop transfusion immediately, take measures to keep normal BP and urine output. Dehydration and diuretics must be maintained. Recheck groups, recross match, take blood cultures, follow signs of hemolytic anemia, and is any anti-globulins test required, renal function test you should do, treat accordingly. There is a dialysis generally we are supposed to in this case. Delayed case, like one in 2500 to one in 6000 cases, generally delayed hemolytic reactions will be taking. It is not immediately. This onsets 3 to 21 days after transfusion. Here this is not delayed hypersensitivity or delayed reactions are not because of ABO grouping. It is because RH and KIT, like other antigen antibodies and mismatches. And some see here, some clotting proteins also will make the antibodies. Even these clotting proteins, antigen antibodies reactions also will lead into the delayed reactions. Generally, it is not detected, but if it is detected, also you cannot do. And febrile reactions, febrile like tissue level reactions are concerned. It is 0 to 0.5 to 3% of all transfusion will lead into the febrile. Febrile is there's vibration kind of thing. So when a patient is given this blood transfusion, even you can see some shiverings one get. So antibodies against white cells are, these antigen antibody reactions are leading, weak reactions are leading into the febrile reactions, fever, chills, increased pulse rate during or after transfusion. These are the signs of febrile reactions. And antipyretic, antihistamines, if you can use a larger extent, we can reduce. So for normal IV transfusion also, the doctors will give this ranitidine or some paracetamol to prevent this febrile kind of reactions. Stop transfusion if there is a doubt about hemolysis. What happens? You must have seen sometimes, if even in the movies, you must have seen when the blood transfusion or IV transfusion is there, that the patient gets chills and fever, chills, shiverings. There is febrile reactions. Prophylaxis, white cells reduction, we can do. Allergic reactions, antibody against donor plasma proteins. This is plasma proteins I told you. And pertussis, urticularia, edema, and anaphylaxis, bronchospasma. These are could be the reasons of allergic reactions. And IgA deficient patients are under the greatest risk in this case, and treat according to the type of reaction. For IgA deficient patients, use washed or frozen red cells instead of regular cells. Pulmonary hypersensitivity, in these, 1 in 5000 is the frequency. Here leukocytes incompatibility and agglutation of white cells inside the pulmonary vascular area, leading to the complement activation and endothelial damage, which leads into the pulmonary edema. Leukocytes here, WBC, simply WBC, which are there in the lungs. See, lungs will be taking the blood for the gases exchange, where the WBC which are not having the matching, they will do the reaction. So they will be they will be reacting with antigen antibody and precipitated over there. And whenever the reaction precipitates over there, then it leads to the edema, reaching of water over there, and which leads to fever, chills, tachycardia. There's increased heart rate, chest pain, and there's hemostasis, BP fall within 4 hours of transfusion. Respiratory support may be necessary. Transfusion related to graft, like something, if you are putting a graft over there, that also, see, generally in such cases the immuno rejections are there, and in such cases we'll be giving the for reducing the immune response, we'll be giving certain drugs. Steroids are given in such cases. So in such cases, what happens, generally the immune response will be less. So this transfusion related issues will not be coming. But as soon as this immunodepressing drugs effect is over, then it will lead a, so you must be careful if you are doing the transfusion to the immunocompromised persons. See, these are the sensitivity reactions with blood transfusion. You can see the edema. Pulmonary edema also will come, but this is a hands. Circulatory overload. So, see, if you are increasing, normally doctors what will do, the BP is a parameter for doing the transfusion. So if the BP is not increasing, still if you are going on by giving that blood, blood transfusion, if you are going on, then what happened? Circulatory overload will happen. Old age and premature newborn or the patients with cardiopulmonary compromises are under risk with this one. Acute heart failure it will lead, and as an acute myocardial failure, whatever the treatment that you are supposed to do, you are supposed to do, because more pressure is applied on the heart. Prophylaxis, low infusion rate you are supposed to do, and low volume of transfusion you are supposed to do. And bacterial contamination. Sometimes the hemolytic reaction may be due to bacteria. So, Staphylococcus aureus, Streptococci, they are known to cause the lysis of RBC cells. So, in such cases, what you need to do, see, it may lead into the mortality, the death of the person also. So, you are supposed to stop the transfusion. Generally, this can be identified easily if the patient is having like what you call the fever or the other signs along with the hemolysis. Normal hemolysis, fever does not comes, only chills comes. But here in this case, fever also will come. So what you need to do, you are supposed to give that immediately stop the blood transfusion of infected blood, and you better give some antibiotics and fluids, and check for the kidney damage. Air embolism, see, sometimes along with the blood, little amount of air will enter, and this will create a lot of problem, and actually it will lead into the acute respiratory and circulatory failure, and clumps the tumbling, and change the posture. What you are supposed to do, you are supposed to change the posture of the patient when if he's sleeping, supine position it is called as. You make him to stand, like elevate, something you are supposed to do. This is a blood transmitted diseases that we are having a separate session for um, blood transmitted diseases and hemophilia, that we are having a separate unit. We will discuss later. So this is all together about the blood transfusion. And anyhow, we are having a book of blood transfusion. I'm having my own written book is there. I will circulate to you, which is more than enough for your preparations. Okay, when is your microbiology exam? Theory exam?
Fourth, sir.
Fourth. Fourth is Friday. Fourth is Monday. So on the same day, you'll be having the practical exam also, and internal also for the people who have not written internal so far. So come with your record book on the same day. Okay. So as you have to prepare for the exams, just I'm leaving you.